Okay, so I'm going to introduce myself for this session. So for the next 20 minutes, I'm going to go through our updated sepsis forms, but I'm going to start off by just going through a little bit of the pathophysiology of sepsis to set the clinical context that led into our update. So sepsis. So over millennia, our bodies have developed multiple levels of defense against infection. And so things like the skin and the mucous membranes act as physical barriers. The pH of our skin is intolerant to pathological microorganisms. We've the mucociliary pathway that clears foreign bodies that we inhale. The hairs in our nose capture foreign bodies. So we've all of these physical barriers. But if those physical barriers are breached, either from an accidental cut or a surgical incision or an ulceration, and that barrier is breached, there are very specific cells called dendritic cells, and the Langerhans cell in the dermis is a specialized dendritic cell. And these cells have receptors on them that are directly activated by microorganisms. So be it a gram-positive or gram-negative, a virus or a fungi, those bugs directly attach themselves to those dendritic cells and stimulate a whole host of responses. So one of the early responses is phagocytosis, where the organism gets engulfed and physically broken down by the dendritic cells. But they also release a cytokine response, and cytokines are signaling agents, and they institute a whole host of responses. They cause the temperature in the area to increase, so you get local heat because bugs don't function or replicate well with raised temperatures. They cause increased blood flow to the area, so local vasodilatation and increased blood flow to the area, so you get redness where the infection is. And that brings with it the cellular and humoral components of the immune system so that it can fight the infection. It causes the capillaries that are dilated to become leaky, so that the plasma containing those cellular and humoral components of the immune system leak out from the capillaries into the interstitial tissue where the bugs are, so they can kill the bugs. Some of those cells get activated and travel to the local lymphoid tissue where they stimulate T cell and B cell differentiation, so you get activation of the adaptive immune system. So all of these things are adaptive, and we see them locally as swelling, redness, and heat. And if that's enough to kill all the bugs, there's no longer any trigger of inflammation, and the whole thing settles down, there's healing. But if that isn't enough to get rid of the infection, you get continuous activation of the cells, continuous production of cytokines, continuous vasodilatation. So now the heart has to work harder because it has to pump blood into a much bigger capacitance area. So our heart rate goes up, our cardiac output goes up, our metabolic rate has gone up, so our oxygen utilization goes up, so our respiratory rate has to go up. Our CO2 production, which is the byproduct of metabolism, goes up. So that also stimulates our respiratory rate to go up. So you start getting a systemic rise in temperature, your heart rate goes up, your respiratory rate goes up, and of course your white cell count goes up, because these are the soldiers that are going to fight infection. So your body starts producing more white cells. This is all adaptive, and these are the elements of the systemic inflammatory response, and it's all designed to try and get the bugs and kill the bugs. But if the bugs don't get killed, and you have continuous ramping up of this systemic inflammatory response, you're getting a very strong inflammatory drive, the body recognizes that it's under threat, and you start to get organ dysfunction. Now, there's a couple of different theories as to how the organ dysfunction that occurs in sepsis actually occurs. One theory, and there's quite a lot of evidence to support this, that is that it's an adaptive response where the organs go into a hibernation type state. They're under threat, so they go into hibernation and they're shut down. And the idea is that that shutdown is temporary, so that when the threat passes, you get a rapid resolution of organ function and the organism can continue. And we see that very well in sepsis-induced kidney injury, where once the infection is sorted out, you get a very rapid return to renal function. And there's also very good autopsy data to support that theory, where in animal models and some studies on humans who have died of sepsis where they have very early autopsies, it finds that in the organs, despite them having stopped functioning, there's actually very little tissue damage in the organ systems. So there's quite some data to support that. The more traditional theory was that it was due to abnormal microcirculatory flow, and in particularly it was a necrosis due to a deprivation of oxygen due to reduced flow. And certainly in some cases you can see ischemic damage, but it's largely occurs in patients who are on very high doses of vasopressors before death. So these are the current theories, and they are only theories. The reality is that there's been very little investment compared with other conditions in understanding sepsis pathophysiology, and it's only now that we're starting to see some movement. Professor Levy referred to Professor Bone, who was the lead in the first consensus definition of sepsis. And Professor Bone's work was primarily done in a mouse model. And what he found was that in the mouse model of sepsis, that there was a pro-inflammatory response that was subsequently followed by a compensatory anti-inflammatory response. And he called that pro-inflammatory response the SIRS response. And this spawned, 2 to 3 decades of research aimed at, if only we could control this over-exuberant inflammatory response, we would be able to improve outcomes from sepsis. But the reality is that the pro-inflammatory response is adaptive. We need that inflammatory response. We need a robust immune response to fight infection. It's not enough to have antimicrobials alone. And we do see that in our neutropenic patients. Even if we've got them on the right antibiotic, it's often not until their white cell count starts to recover that they succeed in actually clearing the infection. So the presentation of the patient who comes to us unwell is a combination of the characteristics of the microorganism that's caused the infection, but also the characteristics of the host. So the virulence of the organism, the inoculation dose, so very large wounds, or a patient who's been sick at home untreated for a week, the bugs have been replicating all that time, or the presence of multi-drug resistant organisms. We've got genetic polymorphisms in our immune response to sepsis, and we have the comorbidities that we have outlined earlier. So the current theories of sepsis presentation is that really a patient can present with overwhelming sepsis or overwhelming inflammation, pro-inflammatory response, and have a very early death associated with a huge amount of inflammation, or they can actually present with a hypoinflammatory response where their immune system isn't producing that adaptive inflammatory response needed to help eradicate the microorganisms. And indeed, many of our deaths now in ICU are late deaths, are patients who have failed to clear the original infection because their immune system has been suppressed by the overwhelming sepsis, or indeed they've developed a secondary infection and are unable to clear that. So sepsis is complex. That's why we have a sepsis program to help support our diagnosis and management. And The individual presentation can be very varied. The sepsis 3 definition tells us that sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection. And the advantage to that is I think that there's very good clinical consensus with that definition, that really we're all very comfortable that this represents sepsis. However, the big disadvantage is that we've moved from a bedside diagnostic criteria with using the SIRS response and infection to a definition that might require biochemical tests. So there's an inbuilt potential time lag before we can make the diagnosis. And yet the only proven therapy for decreasing mortality and morbidity is early recognition and early treatment. So how do you marry that conflict? The other issue, of course, is the assessment of the clinical presentation of acute organ dysfunction can be very subjective and dependent on the clinical skills of the operator. And what we do have to remember is the first responder in our emergency department in our ward isn't the consultant, it's usually the SHO. So we're not talking about people with a wealth of experience who can have a nuanced approach to diagnosing sepsis. The purpose of the clinical decision support tools is to help support these doctors in making their diagnosis and also to reduce variability, inter-operator variability. And I think we can illustrate this with the case of Rory Staunton, and the Staunton family have been great supporters of the National Sepsis Programme and have spoken at our sepsis summits in the past. And Rory, when he presented to the emergency department, it wasn't with flu-like symptoms. He presented with a heart rate of 130. He had hypotension and he had mottling of his skin. There was nothing subtle about his symptoms, and yet still there was a failure on the part of clinicians to pick up his clinical and understand what his clinical presentations were. We have used the evidence that we've developed from our HYPE database on sepsis in order to inform our updated sepsis forms. And what we have done is we've identified 3 patient groups who have a mortality risk of greater than 20% if they have sepsis. And what we're recommending is that if patients in one of these 3 groups present with an infection, they should be treated with the Sepsis 6 bundle. And then as part of the Sepsis 6 bundle, we send blood tests looking at organ function. And then when those results become available, then we're able to confirm or outrule sepsis diagnosis. So the patient groups include, so this is our clinical sepsis at triage pathway. So if a patient presents with infection, and they are unwell and on receiving chemotherapy or radiotherapy, that puts them at risk of neutropenia, or they have clinical signs of acute organ dysfunction, and we have a list of those clinical signs, or they present with a systemic inflammatory response and have one of the comorbidities that are listed here and that are associated with increased mortality with sepsis. If patients are in one of those 3 categories, they need to be assigned a Category 2 designation at triage and escalated to immediate medical review, and the sepsis form started for them. After medical review, if the history and examination supports infection as the cause of them being unwell, they should receive the Sepsis 6 1-hour bundle. The patient on the ward who's being monitored using the NEWS scoring system, if that patient has a NEWS score of 4 or exercising clinical judgment, a medical review is sought. If after examination, infection is suspected as the cause of their clinical deterioration, and they're in one of those 3 groups, So they're on chemotherapy, radiotherapy for cancer therapy. They have evidence of acute organ dysfunction, or they have a SIRS response and they have one of the comorbidities, then a sepsis form should be started and they should be given the Sepsis 6 1-hour bundle. By 3 hours, the patient's response to the first Sepsis 6 bundle, the first-hour bundle, should be assessed. Are they improving, stabilising, or continuing to deteriorate? Their blood tests and other tests and investigations should be reviewed along with that clinical context, and their organ function assessed. And if there's evidence of acute organ dysfunction consequent to the infection, then sepsis is diagnosed. If their first lactate was abnormal, their second lactate should be performed and used to help guide ongoing fluid resuscitation. And if the patient is deteriorating, there's an escalating, or there's a deteriorating action bundle. By 6 hours, patients who have been hemodynamically stable should have been started on pressors if they haven't achieved hemodynamic stability with fluid resuscitation. Now, this doesn't mean that you have to wait until 6 hours before you start vasopressors. There are some patients who are going to present very hypotensive who are going to need early pressors along with ongoing fluid resuscitation. But certainly, if you haven't achieved a normal blood pressure with a MAP greater than 65, by 6 hours, the patient needs to be started on vasopressors. And thereafter, daily review. Is your patient responding to treatment? If they're improving, follow the start, smart, then focus antimicrobial stewardship policy. If there's no change, you need to review your diagnosis and management and also check for source control. Antimicrobials need a blood supply to deliver them to the site of infection. If you've got an abscess or devitalized tissue, antimicrobials on their own will not work. And if the patient is deteriorating, then you need to review your whole diagnosis and treatment and escalate your care. Antimicrobial management includes stopping if there is an alternate diagnosis and nothing to support infection. And in fact, this can be initiated after the first hour bundle, after the Sepsis 6 has been delivered. So I'll give just a little clinical vignette. So the patient comes in, they have tachypnea, they've cough, they've some pleuritic chest pain, and they have low oxygen levels. And they are diagnosed with a respiratory tract infection. They're at risk of sepsis, so they're given the Sepsis 6 bundle. And a number of tests and investigations are done. And subsequently, by 3 hours, those tests and investigations are reviewed, and it becomes apparent that the patient has a pulmonary embolism as the course of the symptom, not an infection. So at that point, we've got a viable alternative diagnosis, and we should stop antimicrobial therapy and institute anticoagulation if it hasn't been done so already. So at every point of review of the patient, we need to always consider, our differential diagnosis and ensure we're on the correct treatment. We can change our antimicrobials, de-escalating or broadening based on the patient's clinical response to treatment and the results of microbiological studies, and then we need to review the patient again. So what is the sepsis screening in our form? So the sepsis screening for nursing staff is that the patient has a suspicion of infection, so their clinical signs and symptoms are suggestive of infection, and they have one of the 3 presentations that I have outlined. So they're immunosuppressed, they've got acute organ dysfunction that it's clinically apparent, or they have a systemic inflammatory response and they have a comorbidity. And the action is a medical review within 30 minutes, and that's be it presenting at triage or with a news deterioration. And these are the 3 different groups are on our sepsis form, and they're also on our posters to remind people. And we have the comorbidities, the relevant comorbidities listed. Our Sepsis 6 bundle I'm not going to go through because I think everybody's familiar with it at this stage, except just to point out a couple of minor changes. And this is to facilitate people who do granular audit. When we say oxygen therapy, we titrate oxygen to saturations of greater than 94%, or if you've got chronic lung disease, 88 to 92%. So that means that if you're on room air, you're getting 21% oxygen and your SATs are greater than 94, you don't need supplementary oxygen. You've assessed their oxygen levels as being satisfactory, and you've deemed that room air is a satisfactory quantity for that patient, so you tick oxygen for that. Similarly, IV fluids are given to patients with an identified fluid deficit. If a patient has no fluid deficit, they do not need fluid resuscitation. And not everybody with the fluid deficit needs the exact same amount of money, the exact same amount of fluids. I'm getting tired, sorry guys. What we want to do is we want to have targeted fluid resuscitation for the individual patient. The purpose of fluid resuscitation is to restore perfusion in that individual patient. And so we give a bolus of fluid and then we review the patient and rebolus the patient if they require further treatment. Sepsis diagnosis is made using the list of organ dysfunctions and any one of which, if present after our initial sepsis 6 fluid resuscitation with up to 30 mils per kilo of fluid, if organ dysfunction is still present, we diagnose sepsis. If acute organ dysfunction is not present, sepsis is not diagnosed. Now, we piloted the use of the SOFA score versus the use of the organ dysfunction list. And what we found was that senior clinicians, so consultants, loved the SOFA score. NCHDs, not so much. And since NCHDs represent our target population for filling out the form, we went with them. So we're with the organ dysfunction list. We have chosen to just use a requirement for pressors for fluid-resistant shock as our diagnosis for septic shock. So we've excluded the requirement for the lactate because we felt that it wasn't clinically needed in our management of the patients. End user feedback has been a really important part of the development of these new forms. We've piloted them in the emergency departments around the country, and we have responded to the results of those pilots. Going into the future, we're working with our paediatric and neonatal colleagues to develop forms, and we're close to starting a pilot. And we hope in the third quarter of this year to start those pilot studies. I mentioned earlier we're working with primary care and residential groups for sepsis pilots there. And the sepsis mortality prediction model and sensitivity and specificity analysis will be the big audit that we'll be doing next year, because we'll be looking at our 3 identified groups of patients to see, are we picking up the right patients and getting them the right treatment in the right time. We've also produced a number of education aids, both for patients and healthcare professionals. All of these aids are available on our website, which is www.hse.ie/sepsis. The guys love this. We had our marathon runners who ran with one of our sepsis survivors there last year. So I'll be happy to take a few questions. Thank you. So the big change is that we will not be looking for escalated care in patients who have no comorbidities, who present with infection and just a SIRS response. These patients still have infection, they still have to have their infection treated, but they don't need to be reviewed within 30 minutes unless they continue to progress and deteriorate. Okay, we have a question.
Hi, my name is Miriam. I work in coronary care in Naas. I'd just like to know how other hospitals are dealing when they escalate patients to a critical care area. We've got 3 ICU beds for the hospital, and coronary care has 5 beds. And at the moment, coronary care seems to be where patients are escalated to. And I'm just wondering how the rest of the country are finding their escalation for someone with sepsis who's been diagnosed. Where do they send them?
Well, I can only really talk about perhaps from personal experience in our hospital and also from the critical care programme point of view. We have a report that demonstrates that we do not have sufficient critical care capacity in Ireland. That's known. We are working very hard to try and change people's opinions to get the funding to increase our critical care capacity. And there is a recognition that there's a problem, but one of our big problems is to get sufficient critical care nursing to open beds. And certainly in Waterford, we frequently have 2 beds closed because of insufficient nursing staff. Having said that, I'm very much of the view that critical care should be delivered without walls, and irrespective of where a patient is in the hospital system physically, if they have a requirement for critical care, they need to be stabilised and delivered, and then where they get relocated to dealt with then after they've been stabilised. So I don't think that addresses your question, but I'm afraid it's the best I can do.